my camera for a minute, see if I can clean it off. It looks like it's dirty. Hang on a second. Everybody, this is Cassie Sauer at the Hospital Association, and we're in the midst of giving everyone recording privileges. It'll take us a couple minutes, and we'll get started. Andrew, do you think everyone has recording privileges? That are you done with that process?
I'll turn to Cindy and Michelle.
I think we look pretty good. We'll go through and we'll keep moving through.
Okay. Is there anybody who's a member of the media who wants to have recording privileges that does not have them yet? Okay, great. Well, then we will get started. Thank you all so much for joining us today. We are glad that you're here for our release of information about the financial health of Washington's hospitals. I'm going to start by saying who's here with me, and then we'll begin our program. So I'm Cassie Sauer. I'm the Chief Executive Officer of the Washington State Hospital Association. Joining me is June Alteras, who's the Executive Vice President and the Chief Quality, Safety, and Nursing Officer from MultiCare Health System. You all had the opportunity to hear from June a number of times throughout the pandemic. She was a real expert in helping us guide our pandemic response. Daryl Wolf, who's the Chief Executive Officer of Olympic Medical Center in Port Angeles, which is a critical hospital to providing care to people all throughout the Olympic Peninsula. And Dr. Andrew Jones, who is newer to our state and is the Chief Executive Officer of Confluence Health in Wenatchee, also a major service provider in a large geographic region in Central Washington. On the State Hospital Association team, Eric Lewis, who's our Chief Financial Officer, and Shalene Whitaker, who's our Senior Vice President of Government Affairs, are also on, and each of these folks will have a chance to talk. I just want to say, many of you have been on briefings with us before, but just in case, you're welcome to put questions in the chat at any point, and we'll get to them for sure. And you also can ask questions just when we open up for questions, you're welcome to just ask them orally. So, WSHA surveyed all acute care hospitals in Washington state for their calendar year financial results, and we compared the first 6 months of 2022 to the first 6 months of 2023, and we've just got the results from this comparison. We surveyed hospitals for all their operations and got details on their employee wages and benefits, their temporary labor expenses, and any funding that they were receiving for COVID relief. We had good response to the survey. We have about 93% of acute care hospital beds represented in the survey. Hospitals in the survey employ more than 113,000 people and also work with thousands of independent physicians that are not directly hospital employees. I think it's important to start this briefing by reminding everyone that hospitals are absolutely critical community infrastructure, that people across our state rely on hospitals to be there to care for their heart attacks, strokes, trauma, appendicitis, cancer, major surgeries, other emergency and acute care needs. And the hospital is the only place for these services. Access to the specialized care is definitely threatened by unsustainable financial losses. It's also worth knowing that our state spends significantly less for healthcare when compared to other states. The Kaiser Family Foundation is a great source of healthcare information, and they say that Washington state is 40th for spending on healthcare per capita. We also have 32% fewer hospital admissions than the U.S. average. Part of that is we have a lot fewer hospital beds than the U.S. average. Hospitals in our state have historically had low operating margins compared to other parts of the country, and we are continuing to see major losses from basic hospital operations. What we mean by basic hospital operations is just what does it cost to care for patients day in and day out? What are you bringing in and what are you paying out to provide that care? Ongoing losses in basic hospital operations are unsustainable. Over time, they'll result in hospitals reducing high-cost or non-profitable services simply so they can keep the doors open. We've already seen this happen. We are seeing important services get cut We've seen one hospital close since our last briefing on the financial challenges of hospitals. We remain very concerned about the loss of healthcare in our state and the challenges that people have in getting the care that they need. So with that, I'm going to turn it over to Eric Lewis, who is our, as I said, the Hospital Association CFO, to go through the specifics of what we found in the survey. Eric. Eric, if you're talking, you're on mute because we can't hear you. Thank you.
Well, good morning, everybody. In 2022, hospitals across the state lost $2.1 billion. In the first half of 2023, the pace of losses slowed, which is good, but they remain significant. But the losses remain significant, which is challenging, particularly when layered on last year's losses. Total operating losses were nearly $750 million for the first 6 months of 2023. This represents a negative 4.6% operating margin, which is better than last year's margin of minus 8%. But however, it remains unsustainable. Only 12 hospitals or health systems representing only 15% of hospitals in the survey had a positive operating margin. And they were almost all of them were rural critical access hospitals. Several factors contributed to the lessening of total losses, including cuts in services that lose money, reductions in the use of travel or temporary staff, increased revenue primarily due to more patients receiving care such as surgeries, and improvement in investment income. When non-operating revenue is included, statewide losses drop to $159 million, which is a minus 1% margin. Non-operating revenue includes investment income and some funds that supported the COVID response, including FEMA funding. Not having a major COVID surge so far in 2023 also contributed to the increase in revenues for hospitals. In 2022, we saw reductions in surgeries and delayed care as staff resources moved to COVID care. Our staff were out due to COVID. Reductions on reliance of high-cost staffing agencies also helped reduce losses. However, staffing remains a major concern in our state. We are grateful to the Washington State Legislature for passing the Safety Net Assessment. This program provides a major increase in Medicaid payments, but the increases aren't in effect yet. When approved by the federal government, hospitals will start seeing payments in April of 2024. However, these increases do not make up for losses experienced over the last few years, and there will still be a gap between the cost of caring for Medicaid enrollees and Medicaid payments. Medicare and private health insurance will also need increased payments to cover higher hospital costs. Hospitals are continuing to rely on income from investments, spending of already depleted reserves, and cutting services of staff to make up for operating losses. 17 reporting hospitals have less than 3 months of operating costs held in reserve. According to bond rating agencies, in order to have a good financial rating, hospitals should have over 200 days, about 6.5 months of cash savings. Without a positive margin, the ability to build reserves, hospitals struggle to keep inpatient beds open, which is a limited resource in Washington, as we are the 5th lowest number of inpatient beds per capita in the country. Struggle to increase wages to recruit and retain staff, struggle to reinvest in equipment, facilities, and new services needed by the community. This could be as basic as a new roof or updated healthy heating system. Struggle to maintain critical community health services that do not generate revenue and are not core to the acute care hospital mission. Struggle to pay principal on debt. Ongoing large financial losses will result in less access to healthcare for patients. A current example is the loss of OB services in multiple communities in our state. Other OB programs are considering closure due to ongoing significant operating losses. Ultimately, continuation of these losses threaten hospitals with bankruptcy closure, which is devastating to a community and patients.
Thank you, Eric. Eric, did you want to show the actual results of the survey?
I do. Beth, could you share it? This will be sent out to everybody, but this is the results of the survey. And you can see the operating revenue went up 9% for the reasons that I mentioned. I think employee wages and benefits went up 8%, about $700 million. And supplies and other expenses went up 9%, particularly supplies and pharmaceuticals. As I said, the agency traveler costs went down about 300,000 or about 300 million, but they remained really high at $716 million for the first 6 months of 23. I think that the net non-operating loss of 750 million is the big takeaway from the survey. Better than last year's 1.1 billion, but still unsustainable. And the non-operating is primarily investment income. There's some COVID relief, primarily FEMA, but that went down 12%, and you can see the bottom line. But this will be sent out to everybody.
Thank you, Eric. Anybody have questions before we move on about what we just shared? We can take them at the end as well. Okay, we thought it would be helpful to talk about some of the cost drivers. What is continuing to put this cost pressure on hospitals? And just to go through some things that really contribute to this. First is rapidly increasing costs for staff. Hospitals, the vast majority of hospitals' budget goes to cover the costs of staff and payroll. And you have seen media coverage of significant raises for hospital staff. Hospitals increased employee compensation by an average of 8% per employee when you compare the two time periods. The good news is the cost of agency staff or traveler staff has declined by $300 million, but that 8% per employee adds up to increased wages and benefits of over $700 million over the first 6 months of 2023. When you put that into a year figure, it would be at least $1.4 billion, but there's many contracts still in negotiation, so that number could even go up higher. We also face generous leave laws in our state that have staff calling out and needing to be covered, often in the last minute, and that definitely contributes to staffing costs. All of us are affected by high inflation on a variety of goods and services right now, and hospitals are not exempt from that. So we've got drug costs, energy costs, supply costs, all increasing faster than payment rates, and we've seen the cost of goods increase by nearly 10%. We also have more complex patients whose care costs are much higher than reimbursement. The way hospitals are reimbursed is they're paid by condition, and if you've got a really complex patient who needs a lot more care, that can very much drive up the cost of caring for that patient. We've talked to you all before about patients who are ready for discharge, patients who have complex discharge needs, who are not able to secure placement in nursing homes, adult family homes, or other post-acute facilities. And our panelists will talk about this in their own hospitals. Hospitals get paid very little or nothing to care for these patients once their acute care issue is resolved. And additionally, hospitals lose revenue from patients whose care is delayed because the beds are full. I want to be clear about a point that we hear sometimes from state officials. They say, well, it's just one person taking up one bed, but if they've been in that bed for 90 days and your average length of stay is 3 days, they've been taking the place of one person, they've taken the place of 30 people. And often it's even more than that. Hospitals are reimbursed into fixed government fee schedules and fixed contracts with insurance companies. They don't have the ability to just raise prices like a restaurant or a hotel might in order to cover higher costs. And especially those government programs, Medicare and Medicaid, between 60 and 80% of hospital patients, and each of our panelists can share their figure, are insured by government programs, Medicare and Medicaid. And these programs significantly underpay hospitals compared to what it costs to provide services. And that is a fact that is acknowledged by both the state and federal government. So I'm going to turn this over to Shalene to talk about some of the solutions that we are continuing to pursue in this area.
Great, thank you, Cassie. So we are asking the legislature and state agencies to continue to partner with us, continue to work on solutions for complex patients. We do applaud the investments that were recently made in the 23 legislative session to increase rates to long-term care. We also are anxiously waiting a pilot program to start for 5 hospitals across the state to help get patients care they need in the setting they need, and will help free up hospital beds. And these need to go into effect soon and be implemented with minimal bureaucracy. We also we want support for implementation of the new staffing law that allows and to allow innovations in care delivery, including recruitment and retention of staff. We are always concerned if we begin to hear about any payment cuts. As you just heard, the financial situation for hospitals is not good in our state. So we would be concerned about payment cuts, and we'd like the legislature to continue to look at potential investments in services like rural OB. A couple other additional points. We would be concerned about imposing legislative mandates that would add cost to hospital operations and threaten access to services. And our panelists will talk about what they're doing in different parts of the state to ensure access, especially in Yakima. And additionally, support hospitals' ability to find creative solutions to maintain access to services, including partnerships and affiliations with other organizations. And lastly, we need help shoring up other critical pieces of the safety net that are outside of the hospital, including alternative placements for people who do not need emergency room care, but need some sort of care. This could be things like mental health and substance use disorder services, which our state has made some investments in, but again, it's been really challenging and continue to face workforce shortages and low payment rates. So with that, I will turn it back to Cassie.
Thank you, Shalene. Okay, now we're going to hear from our hospital panelists. So we'll start with June Alteris. Go ahead, June.
Thanks, Cassie. I'd like to give some examples at the local level that Eric and Shalene and Cassie spoke so eloquently about. So first and foremost, I will say that this issue of hospitals closing and decreasing services in communities is real. If Yakima had not been able to join Multicare, there's a very real possibility at one point in time that hospital may have closed. And I'll give you some examples of the state when Multicare was able to join with Yakima. Yakima has gastrointestinal services that are so backed up, and I'll give you an example. So screening colonoscopies, a basic preventive care screening test. Over 1,000 people in a work queue to get a screening colonoscopy. Neurocare. Many patients in Yakima have had to be transferred out of Yakima to receive stroke care, either in Seattle or Spokane or Tacoma area. Remember, time is tissue. Time is very important to our hearts and brain, and that delay in care causes strokes to have a worse impact than they may have had if we can intervene timely. We are having early success with Yakima. We've been able to recruit physicians. You cannot bring clinical services back into a community without physicians. We are committed to bringing back anesthesia, GI, neuro, pediatrics, cardiac. We are working on this right now, and we've had some early successes. We've been able to recruit 13 physicians, 7 APPs. We've also been able to recruit 78 RNs. And so now Yakima has the lowest traveler percentage of all of our hospitals throughout Multicare system. So we're really happy about that. And we have 40 more recruitments in process. So we are making progress on bringing those clinical services back into Yakima Valley. And people spoke about specialty services. We're talking about basic services. You can't do surgery without anesthesiologists. To not have enough physicians to be able to do screening colonoscopies or to take care of stroke patients in a timely fashion. These are not super specialty services. These are basic services in clinical you would expect to have in any community. We also are concerned, we are an ecosystem. Healthcare is an ecosystem. I know we focus on hospitals a lot, but having said that, the entire ecosystem has to work or it impacts someone else. And so these barrier patients, as we call them, they no longer need an acute care level. And we don't have enough post-acute services. We don't have enough ambulatory primary care. Access is a real issue in our state. And you know, for me as a nurse, it's not about the money. What I see is the very real backing up of these patients in our emergency department. So patients who need to be admitted into a medical surgical unit or a progressive care unit are in our emergency departments. There's a lot of research out there that shows us that for every hour after the decision is made by a physician to admit a patient, for every hour they stay in the emergency department, their morbidity increases by 1%. And this is simply because ED physicians and ED nurses, this is not their training. They have their specialty training, and when someone needs to be admitted, they need to go into the hospital to be cared for by a hospitalist, an intensivist, and acute care RNs. And so this has a real impact on our communities. And even though multi-care is one of the largest behavioral health offerings across the state, we still are a safety net within our hospitals. Many of our patients that are sitting in our emergency departments are behavioral health patients. So there's simply not enough access yet in our community. And speaking about how do we take care of our clinicians, how do we take care of the burnout and exhaustion and the shortage of clinicians? For nurses, the nursing shortage is not going to go away. We have been in the primary care nursing model for 35 to 40 years. It's not sustainable, and it's becoming too much of a burden on our nurses. It worked when the acuity in our hospitals was less 30 years ago, 25 years ago. It no longer works. We need to be able to pilot different care models to figure out how do we decrease the burden on our RNs, have them doing what only RNs can do, which is evaluating the plan of care, coordinating care, doing transitions of care, chronic care management, as well as prevention of illness. We need to find roles. We need to redesign our care models so that we decrease the burden on our RNs, help them, and have a model that can control the cost of care. And back to you, Cassie.
Thank you, June. I have to find my mute button, as always. Now we'll hear from Daryl Wolf.
Thanks, Cassie, and thanks for having me today. I just want to spend a few minutes to talk about Olympic Medical Center and echo most of the comments made already. Our situation is very similar to what Eric talked about in the overall hospital survey. But for those that don't know us, we have two campuses. We have one in Port Angeles, where our main hospital is. We also have a campus in Sequim. We employ 1,650 people. We're the largest employer in our area. We have an employed provider group of over 110 providers. We're a level 3 trauma center in our emergency department. We're a rural referral center for the west end of Clallam County all the way out to the Pacific Coast. We have a 67-bed operating capacity at this time. Our average daily census is about in the low 40s. I think the biggest challenge Olympic Medical Center has is related to our payer mix. I gotta stop moving. I think, for years, Olympic Medical Center has survived on a pretty slim margin. 3 or 4% has been a pretty common theme for us for many, many years. And what we've seen in the last several years is as costs go up, that's what we're talking about. But what's interesting about Olympic Medical Center is about almost 85% of our revenue comes from one of the government payment mechanisms that's been described earlier in this call. About 60% of our revenue comes from the Medicare program, and about 18% is coming from the Medicaid program, and there's a few small government payers. But what we've seen happen here in our communities is our payer mix shrink on the private payers, or the commercial payers as we call them, down to about 14% of our overall revenue. And as we've talked about, Medicare pays approximately 80 cents on the dollar for the services that we provide, and Medicaid much less. That will be enhanced next year with the Medicaid SNAP program, which we appreciate. But overall, this is an unsustainable equation for us. The ability for us to go to a 25-bed critical access hospital size and be on a cost-based reimbursement model will not take care of the needs of this community. And so we find ourselves in a very difficult position going forward. We've done all we can to control costs as we came out of the pandemic, where us, like many hospitals, we were the testing centers, we were the vaccination centers, we were standing up clinics over a weekend, we were turning half of our hospital into negative airspaces for surges and COVID patients, et cetera. We built up a lot of infrastructure from over those few years to meet all those demands, and a lot of that's gone away, and we're thankful for that. COVID's still here, But the federal funding that helped us through those times is gone. And for Olympic Medical Center, it's been gone since the beginning of 2022. So here on the ground, we're doing all we can, but we're faced with a very difficult situation with our payer mix is not going to improve. We will be looking at opportunities to improve it and find market where we can to try to bolster our commercial payments. But it's a difficult situation because there's just not a lot of industry out here at this time, and I know there's a lot of agencies working on that. So we're in a tough spot. I know overall I believe the industry is looking at consolidation with a close eye. We want to stay independent. That is our mission. That is our goal. But again, being paid 80 cents on the dollar for 60% of your work is just not it's not sustainable. And so the future of Olympic Medical Center is in the short term, we will keep doing what we're doing, and we'll continue to serve as we've pledged to do. But long term, I'm very concerned about an organization of our size, where we're not cost based and we just don't have the critical mass of a larger institution for the commercial payment systems. So that's a little bit about OMC. I'm happy to answer any questions later in the call, but I just wanted to share that with you. So thanks for letting me speak.
Thank you, Daryl. And just to emphasize the point, that geographic area that is served by Olympic Medical Center is immense. And if Olympic cuts its services or, God forbid, were to close, it is a dramatic impact on the whole Olympic Peninsula community. If you take out your maps and look at what else is out there, it's a long way.
Yeah, I think that's a good point. And, we serve about 75,000 people, generally speaking. However, Olympic National Park has a huge summertime draw. So, about 1 million people approximately come into town per year. We're taking care of them as well. But our home health agency serves the whole entire county, which, to Cassie's point, is a pretty significant geographical area. And we're also about 18% of our admissions come from Forks, a critical access hospital, Forks Hospital. And so, they depend on us to survive as well. They unfortunately last year had a period of time where, they couldn't provide OB care. They came to us. We were happy to help them, but we don't have that option. Patients that show up here, we take care of them and we do the best we can. And, all the things June talked about with just behavioral health challenges, substance abuse challenges. As my old boss used to tell me, society's problems are in our ED, they're in our clinics, and they're in our nursing units, and we do our best for those folks, but it's very challenging. So thank you.
I think it's also a real significant issue of equity. The Olympic Medical Center serves a very large tribal population as well, and that's the option for acute care for multiple tribes out of the Olympic Peninsula.
Yeah, there's 5 indigenous tribes that we serve in our region, and that's a good point. Thank you.
Before I turn to Dr. Jones, I also want to point out, our hospital leaders saying these things is hard. They don't want to be in a public forum saying things are really very, very challenging financially. We may be cutting services. It causes panic in their communities. And so for them to be willing to talk about this means it's quite serious. So I want to really emphasize that point. I know, Daryl, that's been a challenge for you all, as to how telling the truth about your financial situation is causing a lot of anxiety in your community.
Oh yeah, no, I haven't slept in 2 years. No, I'm just kidding. But no, it's a tough season, and no, we're doing it. We're meeting with our public. I mean, that's who we serve. I mean, I tell everyone that applies here, we serve our friends, neighbors, and loved ones, and so we owe it to them to be honest and transparent. And it's hard to sit in a public forum and tell this story because it's very uncomfortable. And I'm graying here all the time. It's a tough spot. And you're right, Cassie. I'd rather be talking about how we're the safest hospital in the country or in the state, or doing a lot of really amazing initiatives. But unfortunately, the finances are such that's kind of ground zero for a lot of what we do day to day. So thanks.
Thank you. All right, Dr. Andrew Jones, also serving a quite large swath of our state in Wenatchee, and the biggest hospital, surrounded by a lot of small hospitals, but it's definitely the biggest hospital in that area.
Yeah, thanks, Cassie, and thanks to everyone for being here. I'm going to do a lot of echoing of my friends who spoke before me. So at Confluence, we've had similar challenges to all the other hospitals in Washington. It's been a very challenging year. We serve 4 counties in north central Washington, Grant, Douglas, Okanagan, and Chelan, a large area. We employ about 4,000 people in that area, and we're a very big part of the medical ecosystem, and we have lots of friends over here who work with us. So I'm going to talk a little bit about how we managed through the challenges of the labor situation to the extent we have, and what the compromises we had to make to do that. I want to talk a little bit about how we work with other hospitals and facilities in the region, and also touch a little bit on sort of the mergers and acquisitions question. So I think, as was mentioned by many folks before, we realized in 2022 that the continued reliance on contract labor was unsustainable. So to give a little tangible example, in 2019, Confluence Health spent $3.6 million on contract labor. In 2022, we spent $54 million on contract labor. So we're not that big an organization. That's a tremendous expense, and that's what it took to keep all of our beds open all the time, even when they were not full at the height of COVID and other times. And certainly we had support from many people to do that. What we realized is that we had to closely match our available, how many beds we made available to the staffing we were able to provide, and minimize our use of travelers. And that's been our journey for the last year or more, and it's been very difficult. While we haven't had to decrease any specific services or have major closures, we've had to closely match to capacity. And what it has done is 2 significant things. First of all, I'm very concerned about, and to echo Daryl, our access to capital. So we do not run to have the ability to reinvest in the things we need to do our business. We need at least a small operating margin to be able to spend on new things, and I'll give an example of that in a minute. We also remove sort of any slack or excess capacity that we have. So that sounds great, but the lack of any small amount of wiggle room makes operating a business very difficult. It's much harder to move patients around. It's harder to do things. It makes it hard for staff. It's very stressful. But those are the compromises we've had to make. To go back to the capital piece, we recently, just as an example, like everything in a hospital is very expensive. It's like an aircraft carrier, crazy expensive equipment, all very custom, all of which has to be replaced every 5 years. We recently realized we needed to replace some hospital beds, which is for the good of the patients and the staff, and they have new technology. To buy, some 80 hospital beds is about $2.5 million. And in 5 years, we will get to do that same investment again, and it will cost more. Why has this had so this may all sound like sort of marginal impacts on the cost of our business. Hospital medicine is a high volume, low margin business. So in the best case scenario, historically, the revenue from each patient sort of barely exceeded the cost of providing the services. With these sort of seemingly small changes, and sometimes bigger changes in the cost of labor and other things, that situation was flipped. Services that had a small operating margin to help sustain the business went to being a cost for the organization. So that's been our journey with working on contract labor. And as was mentioned, our costs, our revenues have stayed flat where our costs have gone up. So a little bit about the impact of working with smaller hospitals in our region. We have many critical access in other hospitals in our region, and we work very well together, and we view it is very much a team effort. Our mission statement is local care by and for our community, and we consider this 4-county region our community. We know we take care of our own people and our friends. We have seen instances where people are traveling further away to see us than they usually would, often for specialty care, and often from outside our 4-county area. We've seen hospitals in our region have to cut back on the services they provide. We have done our very best to always be there for our friends in the region, and I think we've done a good job at that, and we have not always been able to do that, but we have mostly been able to do that. But if you wonder why you see in the media so many hospitals and other facilities, closing specific services, there are some services that have always run at sort of a loss to the hospital or health system, and these are the ones you see closing. We have not had to do this, but this is why you see OB services, pediatrics, behavioral health, these kind of things being closed in an effort to survive. So one last thing I want to touch on is there's always been a lot of concern about mergers and acquisitions in the health system world. And I think, like Daryl, we are an independent health system, and that is very much in our ethos and very much who we want to be. It's probably the thing that people at Confluence agree on, even on the days when we don't agree about anything else, and it's a difficult day. I want to talk a little bit about how we have grown over the last 10 years, because we have grown. But we have grown largely from taking on practices and services that were going to be shuttered or cease to be provided by smaller operations or providers in the region. Folks who were going to leave the business, retire, not be able to provide services. We have clinics and facilities from Wenatchee all the way up to the Canadian border through 4 counties here in central Washington, some bigger facilities and some smaller facilities. But we have grown largely exclusively through taking on care that was going to not be provided for financial reasons from other doctors, hospitals, and facilities. So that's definitely the situation here at Confluence. Again, we very much value our independence. We very much are wanting to remain so. We take care of our friends and neighbors, and it is, I worry, like Daryl said, I worry very much about the cost of labor. I worry very much about the cost of our capital, because I want to be able to invest in having great places for our patients to get care, great places for our people to work, having nice facilities that are what we need. And that is increasingly going to be difficult with the very slim margins, some of the none margins we've been able to sustain. So that's a little bit of the story of Confluence. And I'm also happy to take questions later.
Thank you very much, Dr. Jones. Really appreciate that. And appreciate your clinical view as well onto the impact of patients, for sure. So I'm going to start going through the questions in the chat. Please feel free to jump in if you have a question you'd like to ask orally as well. And I'll ask all the panelists to kind of be looking through the chat questions too, in case you want to add something. So Eric, I'm going to send the first question to you, which is on the data. Did the overall number of hospital staffers change, the full-time staff, not travelers? Did we collect that information in the analysis?
Yeah, I looked at that again yesterday, and 113 FTEs currently. 113,000. 113,000. Was I off? Yes. 113,000 is a slight increase from the prior year, just a few percentage points.
And Eric, isn't it true that we had 98% of hospital beds before, and we have 93? So we'd probably expect that number to go up a little bit as well, because we are hearing that hospitals are hiring contract labor, are becoming employed.
Yep. Yeah, but I think the FTE count did go up by a few percentage points once I factored that in.
Thank you. Okay. The next question is, which services have been cut? And Dr. Jones shared some of those services: OB, pediatrics, behavioral health. The other thing that we have seen, and June also shared some of this about what's cut at Yakima, which was pretty dramatic. The other thing we've seen is a lot of hospitals have closed on every unit. They've closed a couple of beds, or they've closed a unit of just their regular medical surgical unit. So it's not necessarily closing a service line, but they are able to take in fewer patients for that care. And then the question was, anybody panelists want to comment on that? Anything specifically that you've closed or you've heard has been closed by your peers?
I would just add, I think what Dr. Jones said is right. And I would just say here at OMC, we've had to, I would say, modulate or moderate some services just based primarily on staffing. In our walk-in clinic, in our campus in Sequim, we've had to close that down largely just a few days a week. But it wasn't necessarily a financial thing. It was more a matter of we can't staff it. But by and large, our mission has been to keep everything open and do our best to make that happen. But aside from the example I mentioned about, I know Forks had a shortage in OB. I know OB shortages across the state have been an issue. So that's the only ones I'm aware of. So, but I just wanted to throw that in.
We've had several OB services close, and more are considering it. And then you asked a question about a hospital that closed, and I put information in the chat about this. If you can't see it, let me know. But it was Cascade Behavioral Health in Seattle, and then I put a quote from their spokesperson about why they quoted, which was the breadth of challenges create a solution where the long-term viability of the hospital is no longer sustainable. So they say it's due to financial challenges. Another question, do we know this, Eric, I think goes to you, and I don't know if we know this. Do we know the dollar amount of bonds issued by hospitals in the state right now? And how many, if any, hospitals have defaulted on their bonds? And I think I would add to this, Eric, I know there's several that have been downgraded or at risk of default. So, so if you could share that as well.
Yeah, I think hospitals statewide have over $10 billion of bonds outstanding. It's kind of like hospitals are very capital intense and they have mortgages on their property and equipment. So on that $10 billion, there's definitely been multiple downgrades of systems and hospitals in the state. I don't know of any hospitals in default, but some hospitals are faced with the challenge of a technical default. The covenants in their bond documents may say you have to have 60 days of cash, where if you fall below 60, you're in technical default on your bonds. And I think that's going to be a big issue as cash reserves are depleted for a lot of hospitals statewide.
Thank you. Eric,
can I add to that, Cassie?
Yeah, please. Yeah.
Well, one thing that we're experiencing here is, and Eric alluded to it, but I think part of the problem now is as hospitals try to refinance or look at new options for capital, those options seem to be shrinking significantly to what they were related to some of the things Eric mentioned. And so I think as hospitals, as OMC has historically had very low debt, and we were very proud of that, it's going to be harder and harder for us to find capital. And I think that's worth noting. Dr. Jones gave some great examples of what it takes to run these places. And I think access to capital, I'm afraid, is also going to shrink. And bonds that can be called will be called. So anyway, just want to throw that in.
Yeah, Daryl, I want to echo that. I mean, I saw somewhere, I did not make up the quote, but I saw somewhere it's called a twindemic, that we have like the sources of the cash that we have from our operations in the past to sustain us are dwindling, and the ability to get new capital is going to be diminished. A very simple way to think about it is the interest rates are so high. Even if you can get it, the cost of doing it is so high that you will not be able to. So it's the long-term sustainability of facilities is very challenging to maintain in that situation where you don't have the operating margin to sustain it.
Thank you, Dr. Jones. And June, you've got your hand up, I see.
Thanks, Cassie. I just wanted to give a little anecdote. One of my fellow chief nurses in the state called me for some peer-to-peer support a couple nights ago. She was being asked to decide between ventilators or dialysis machines to purchase. And those are very basic equipment to deliver typical care in our hospitals. That's the type of impact this is having. And she was having moral distress over being placed in that position and trying to decide that.
Thank you. I'll share a personal anecdote, which is my middle son needed surgery this summer, pretty significant surgery that required an inpatient stay. We had a very hard time getting it scheduled. And I understand the hospital system. So I had a front row seat to how the capacity challenges exist. It was quite challenging. I'm going to ask Eric or Shalene or Beth to put the answer to the question about the losses for the first 6 months and how it compared to the same period last year, not including stock losses, into the chat so everybody can have it written down. Can one of you do that? Eric, Shalene, or Beth?
Yes, in fact, I think we can put the PDF of the income statement, which has that.
Great, thank you. Okay,
right,
I think it'd be better to write it down than say it again. If that works for everybody. Okay, another question, which is, are nursing positions the most difficult to fill? Beyond nursing, we've mentioned difficulty filling other roles, but what are the other positions that are most challenging to recruit and retain? June, I'm going to hand this to you.
Thank you for that question. I think there's more attention on nursing because obviously nursing is the largest part of the workforce in a health system, because if you need to be in the hospital, it's because you need 24/7 nursing care. So we're a large part of any health system. Having said that, the shortages in other professionals also impacts nursing. So respiratory therapists, most of our therapies are our physical therapists, our occupational therapists, our lab personnel, our imaging personnel, our technicians, and it's also becoming increasingly difficult to recruit physicians. There is also a physician shortage looming just as nursing. And so again, we're an ecosystem. And when we're short of these other professionals at the end of the day, it is the nurse at the bedside 24/7. And so the nurse ends up picking up those responsibilities because most of those things nurses can do. And that's one of the things we're talking about in redesign. How do we leverage technology and other roles to take off some of this burden?
Now, I'm going to keep going with my personal anecdote with my son having surgery this summer in a hospital that was doing some innovative care delivery. And it was really, again, this is another thing I talk about a lot, and I got to experience firsthand. He had a compromised respiratory function at one point, which is, not a sentence that you want to hear as a mother. And the regular nurse that was caring for him was a newer nurse. She was really good, but she was a newer nurse. And she called for a resource nurse who was sort of a more experienced nurse who was there in, I think, maybe 45 to 60 seconds to come do an exam on him and determine whether it was something that needed intervention. And at other points, we had folks who were nurse techs, who were nursing students, who were able to perform sort of up to the level that they had learned, who did things like remove his IV. And this one nurse tech was amazing. She was so sweet and young. So my son really liked her. And she showed him how she was going to move the IV, and she showed him what the tube would look like. He was scared about having the IV removed, thought it would hurt. And she was able to spend the time like really relating to him. And it freed up the main nurse. So that we had this main nurse who was able to call the resource nurse for more advanced care and able to call and have the nurse tech do a lot of other services. So I thought it was a really neat, obviously didn't want to be in the hospital with my son, but I was really glad to see how this actually worked on the ground and see this team of nursing that cared so expertly for him. It was cool. The question about where is Wisha Hospital seeking solutions? This is some of what Shalene went over. And Shalene, do you want to reiterate some of what we're seeking solutions? And there, I think that state, it's federal, and it's also different business models. I think it's yes to those three options. But Shalene, maybe you could share again a few of the top ones.
Yeah, thank you. Thanks for the question. I'll share first that I think, as you heard, rural OB is a service line that is very difficult to sustain for a variety of reasons. And we are asking the legislature to consider potential investments in that area. In particular, the payments to providers are very low, and there are losses occurring, and that puts pressure on the hospital's financial situation, as you heard on the call today. So rural OB would be an area. The other pieces that we are asking the legislature for help is to not impose legislative mandates that would add more cost to hospital operations. As you all heard today, staffing is very thin through hospitals in terms of administrative staff. Anything that adds complexity to that area is challenging, and anything that threatens access to services in terms of cuts to hospitals on a financial level is challenging to be able to continue to deliver high quality access care. The other pieces that I think June and others talked about is the fact that healthcare is an ecosystem, and when one area of the healthcare system isn't operating and functioning at its best level, that hospitals feel the impact of that. We've seen that through the pandemic. I mean, we saw it leading up to the pandemic around the issue of complex patients and the pressure it puts on hospitals and staff, and that patients aren't getting the right care in the right setting. So complex patients, continuing to look at solutions there, specifically in that area, looking at, could we look at the court systems and the guardianship process in terms of improvements to reduce the time that people are waiting for guardians to move to post-acute care settings. The other piece that I'd mention is investments in mental health, substance use disorder treatment programs. There's just a tremendous need in our communities that is not being met on those services. And it takes a while to build the workforce pipeline. And we need to continue to do that in our state because our population is growing and those problems are not going away. So there's a couple things that I'd add.
Hey, Cassie, can I add one thing to that?
Yeah,
I
go
think
ahead.
those are all, and thanks to Wisha for working on all those things. Those are all really important things. I think June mentioned it, and I'm sure everyone else is also, each of us as hospital and health system leaders are also working on redesigning services at our sites and how do we do things differently and better and more cheaply and better to use the resources we have. So I think everyone is working on that in multiple areas of their business. So I don't want to, just want to make sure that we know we have to, we have to get as better as we can, and we're actively working on it. And that's going to help, but it's not going to be enough.
Thank you. I think a couple other things. Shalene mentioned the substance abuse and mental health challenges. And a lot of times patients or people, not patients, people are brought to the hospital. As Daryl said, the social ills come to the hospital. So someone is disorderly, they're drunk, they're high on the street, and the police are called. And if the police pick them up, they bring them to the hospital. There's not actually a medical issue at that point, but the hospital ER then has them in their ER. And so looking for other places where we can think of how patients could go elsewhere in the state, what other options are there, and what other care settings could be created, but ones that have already been passed, like a 23-hour crisis facility that legislature passed. We'd like that to really be on an expedited path to get implemented in our state. I also think in the cutting of services, nobody wants to cut these services like OB. It's a really big deal to cut a service like that, but the margins from other services that used to offset and subsidize the cost for something like OB, especially if you've got a big Medicaid population. The hospital in Toppenish cut its OB services, and I think their Medicaid percentage was like 80%. It was reported. It's there's a whole New York Times story about it. You can find that number there for sure. But if you've got 80% of your births Medicaid, it's really hard to make it. It's too much of a loss all the time. Let's see. Are we seeing the impact of added costs and security to deal with rising violence, such as metal detectors and other solutions? I'd love for anybody to answer this. I went to the grocery store last night. There was 1 checker and 4 security guards. It was remarkable. So I think this is all kinds of businesses having increased security costs. June, you want to talk about any increased security throughout the multi-care system?
Yes, you're absolutely correct. I think Daryl spoke about it, that we are a microcosm of what's going on in our society, and we're trying all types of different things. We're doing experiments with security dogs. We have some metal detectors. We're utilizing technology. We're trying to find the right blend to provide as much security as possible for all of our team members and our patients inside the hospital, and it does add cost. And I can't really speak to this cybersecurity issue. Having said that, we all certainly had the experience of when Kronos Worldwide went down, and that's what we use for our payroll systems, and that was a huge cost to our organization to do all those processes manually, make sure our teams got paid correctly.
Anybody else want to talk about security or cybersecurity?
I guess I'll just try to personalize the clinical issue a little bit. I agree we're the clearinghouse for society, right? And so you have a person come into the emergency department who isn't acting normally. There could be a whole host of reasons for that: medical, psychological, drugs of abuse, on and on. And in the emergency department, there's a bunch of trained, skilled professionals who are going to try to figure out why that is the case. And so the tension is to treat this person who's having possibly the worst time of their life with tremendous respect and care, and keep the staff safe if that person happens to not be acting normally. So Our staff do a tremendous job with this. We, like June mentioned, we have a host of programs to deal with these situations. We do face all the lack of decorum and poor behavior that's seen in society and seems to be increasing, and that we see that in our spaces also. But it's a huge problem, and you put these caring, wonderful people who work in our EDs to try to end the situation of having folks who may be having a problem. They have to sort it out. So it's really tough.
Thank you. Could we bring the income statement back up again to Kate's question to make sure people are, Eric, could you review it again about which number, how you compare this and what number you think is most important? Do you see the question in the chat, Eric?
Yeah, I saw the question. And good question. I think the net operating income, the loss in the first 6 months of 23 of almost 750 million minus 5%, that is showing the revenues from taking care of patients versus the expense of taking care of patients. And I think that's a critical element of the health of hospitals. And I think we focus on that because for hospitals to be sustainable long-term, this should be positive because ongoing losses are just not sustainable. But the net non-operating revenue, that is primarily investment income. And you can see in 2022, it was minus 828 million. And that's because of bond and stock losses. In the first 6 months of 23, they were positive 424 million. And I think the volatility of investment income is a factor for hospitals. I mean, I think the first 6 months were good, but the third quarter was a very bad quarter for stocks and bonds. They went back down, and bonds have been going down dramatically lately. So, investment income is very volatile. And if we had a recession, that could be very negative. Then the COVID relief is the one-time payments to help hospitals get through COVID. But the net income is the total sum of the economic changes for an entity. And you can see last year was 1.8 billion negative due to the investment losses. Much better this year at only minus 1%, but that's really due to investment income and COVID relief, which is non-reoccurring. And investment income is very volatile. I don't think we can rely on that to keep our hospitals open. Ultimately, net operating income is going to have to be positive for hospitals to be financially viable for the long term. So does that help, Kate?
Eric,
Yes,
this is
thank
Shalene.
you so much.
Yes.
Eric, this is Shalene. I love this question because sometimes we see that the revenues are often reported, but the part that's missing on that is the expenses. And I'm actually, I just had a flashback to my mother and father had a small piano moving company. And anytime they talk about revenue, my mom would always jump in and ask, okay, what are the expenses? Because those are the things we need to think about when we're looking at that total margin. So I wanted to mention my mom on the media briefing today. She would love that. So
yeah, I mean, that's a really good point. The expenses of almost $16.9 billion. About 60% of those expenses are for people to take care of patients, and then supplies and drugs, purchase services are also significant. So, but the net operating income is probably the most concerning because that it's kind of unprecedented for 85% of hospitals across our state to be losing money in the magnitude of $750 million for 6 months. That is, I've never seen that in my career. There's often some hospitals losing money or a few, but when 85% of hospitals are losing money, that is very concerning.
Hey, can I make a comment, Eric?
Yeah.
Yes.
I just want to, I think it's worth pointing out too, and I don't know how everyone does their accounting. I think it's very similar in that that's where the reserves are. I mean, this isn't like someone's giving you a check for all this money every month or something. I mean, I think it's worth noting that as we talk about hospitals having reserves of 60 days, 90 days, whatever they are, that's where most of your investments are. That is your reserve. It's not as if someone's giving you a check every month, and I don't know if everybody understands that. And I think it's worth noting that at least at Olympic Medical Center, we have investments, but that's also where all of our reserves are. So I just wanted to make sure to point that out.
Yeah, and these operating losses have to be covered somehow.
All right, let's take the last question, which is, aren't there associated challenges with managing patient expectations in terms of levels of care, scope of practice, et cetera? Absolutely. And people come to the hospital expecting that you're going to have the full scope of services. You're in labor, the hospital can deliver the baby. I mean, I struggle, as I said about my son getting care this summer, I struggled mightily with being able to find a surgical spot and a hospital room for him. And I was pretty shocked by how hard it was. Anybody else want to comment on this about your patients expect you to have everything? Daryl, you said you've closed your clinic some days. I bet people are not happy about that.
Yeah, I know it is very difficult, and that's why as we've all alluded to, that's why we really don't want to be having these conversations, because it's very uncomfortable, it's very difficult. Everyone here works night and day to do the best they can for their communities, and at the end of the day, when you still have to close something, it's very sobering. And on the tail of a long 3 years where everyone's really tired, it's a really rough. It's a rough season, and I know everyone here is trying their best, and I know we're all doing our best to communicate with our communities, because that's how you manage those expectations. But it's, you do your best, and you're still not going to hit the mark all the time, and that is really difficult. Yes.
June, you want to comment?
The most important thing is what Daryl talked about, is us feeling like we're letting down our communities. Having said that, it becomes a negative feedback cycle. Then our patients fill out their patient experience forms, which are reimbursement from Medicare. Almost a fourth of our reimbursement is based on our patient experience scores. And so then we get takeaways in the reimbursement that we already have that isn't covering our expenses. And so the most important part is our patients and our community and their experience. Having said that, it is having an impact on our finances as well.
Thanks, June. I'm sure the people of Yakima who are waiting for months for a screening colonoscopy feel that loss of services too. Dr. Jones, last comment from Dr. Jones. Thank you.
Yeah, thanks, Cassie. Yeah, and I would just note that, in the hospital world, our services, when we provide them, have to be perfect. They have to be perfect every time. And that's our obligation to our patients and our community. So yes, we have to manage expectations, but we do know we have the expectation when we provide a service, it has to be perfect.
Thank you. It's a great way to end. It's really the commitment to patients, every single patient, every time. Thank you all very much for joining us. If you've got further questions, you're welcome to reach out to Beth Zabrowski, and we can get you connected, but I really appreciate your time. And thanks so much to our panelists, Dr. Jones, Daryl, and June. I very much appreciate you joining us today. Take care.